All right, welcome to tonight's webinar, Pillars for Presbyopia Management, Incorporation of Pharmaceutical Treatment and Clinical Practice with Dr. Selena McGee. Thank you so much, Dr. McGee, for being here with us. We are honored to have you.
Thanks for
And
having me.
where are you presenting from tonight?
I am in Edmond, Oklahoma. So, yes.
Amazing. And I love that bookshelf. It's amazing.
Thank you. That was my Christmas project
That's
last
great.
year.
I almost want to have you here to help me in my house. I'm your host, Dr. Elise Kramer. I'm from Miami, and I'd like to thank Lens Therapeutics for exhibiting at this event. Next slide. So this is a 1 hour CE course. So for each hour of CE units, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. Also, the survey link will appear when the webinar ends. CE certificates will be delivered by email and sent to Arbo with OE tracker numbers, but there also will be a QR code. So if you have the OE tracker app on your phone, you can use that to scan the code and get instant CE, but you can't use your camera. So if you don't have the OE tracker app, it won't work, but you'll still get your CE certificate via email within 4 weeks. You can ask questions using the Zoom on-screen floating panel that you see circled below. You can see the chat and Q&A there. And if you go to the next slide, you'll see if you're using the mobile version, it's a little different. The Q&A is going to be at the top. And then if you want to use the chat, you're going to click on those three dots there at the bottom and find more options. We're going to try to keep the Q&A for Dr. McGee if you have any questions for her. If you have any logistical questions, put them in the chat. So I will introduce our speaker who really needs no introduction. But Dr. Selena McGee is the visionary founder and owner of Bespoke Vision. She is a nationally recognized expert at the intersection of ocular aesthetics, dry eye disease, and leadership in modern eye care. She leads with intention and empowers doctors to implement confidently, lead authentically, and elevate both patient outcomes and the profession itself. As the founder of Bespoke Vision and dynamic keynote speaker, she redefines what's possible, one doctor, one patient, one vision at a time. She's an adjunct assistant professor at the Northeastern State University College of Optometry. She serves as a clinical investigator at the Oklahoma Medical Research Foundation. She currently serves as past president for the Intrepid Eye Society and the secretary of the Board of Examiners in Oklahoma. She is a fellow of the American Academy of Optometry and a diplomate of the American Board of Optometry, and is past president of the Oklahoma Association of Optometric Physicians and past trustee of the SECO Board. Most recently, she was named OD of the South and OD of the Year in Oklahoma. She is a co-medical editor of Modern Optometry. She earned her Bachelor of Science in Biology, where she graduated summa cum laude, and Doctor of Optometry from Northeastern State University, Oklahoma College of Optometry. Wow, you're amazing. Thank you so
Thank
much.
you.
And I'll let you take it from here, but I'll be on a little bit later for questions.
Perfect. Thank you. Thanks, Elise. Always great to see you. Here's my financial disclosures. I am super fortunate that I get to work with a lot of different companies, and all of these relationships have been mitigated. So we're going to talk about pillars of presbyopia, and we've had a couple of lectures already this year on presbyopia. One was on, looking at the patient. One was on actually looking at clinical trials. This one is, how do we take all of that information and translate it into what happens every day in clinic? And I always think of the word intentional. And it's interesting, like, as we've been on this journey of kind of highlighting presbyopia over the last 5 years, um, how intentional we have to be. And there's a lot of opportunity here. And so that's what I want to share tonight is, what that looks like in my practice, and then maybe giving you guys, something to think about, because this is a disease state that we see every single day. I mean, think about how many patients you saw today that you diagnosed with presbyopia, or you managed presbyopia, or you prescribed something for presbyopia. We see it every day, and there's danger in that because we get numb to it. We do the same things over and over. Are we really truly seeing what our patient is going through? Do we talk about it? Are we being intentional about it? Do you actually use the word presbyopia? I think that's really important. Do we give them the language for what they're experiencing, or do we just, use humor and, getting old, or birthdays or things like that, without really giving our patients the what this is and what they're going to experience and how we can best help and serve them. Do you offer clarity of what that disease state looks like, or do you just prescribe things and move on? When you do prescribe things, what did you actually say? Do you pause long enough to know how it lands? And did the patient walk away feeling understood or just accommodated? And there's some really intentional words all through that. And do you even remember what you said? When was the last time that you thought about how you described presbyopia and were intentional about that conversation, right? And so we have a good opportunity. And this happened for me 5 years ago when we were starting to work on a therapeutic drop for presbyopia. And then we had our first one approved. And I got very intentional about what that looked like in our practice. And that's what I want to share tonight so that, as this landscape has continued to grow, there's so many opportunities, whether it's spectacles that we're talking about, contact lenses, therapeutic drops, or surgical options. There's lots here to uncover. And honestly, if you told me 20 years ago that I was going to be lecturing about presbyopia to, how many of us are on here tonight? Let's just look, 936 people. I would have said you're crazy, right? Like, this is not exciting, but this is very exciting. And so that's why I'm here, and I'm super happy that you guys are here. So why should we address presbyopia? Because it's frustrating. It's a frustrating condition. It's frustrating for the patient, but let me tell you, it's frustrating for us too. And if you're sitting on the other side of my green light right now and you're like, thank you, I'm super frustrated with a patient that sees 20/20 but is still unhappy. I'm super frustrated with how much chair time it takes to discuss and have a conversation about IOL regret and the technology available when we know there's so many things that go into that. And, what are we thinking about? Like, do we have these self-fulfilling prophecies of what's actually true? And then what do we have that are really myths? Like the fact that we believe that, is this going to really increase discussion times? It doesn't have to. But if we believe that, we're going to avoid that conversation at all costs. And it usually winds up like biting us and causing us more time because there's a missed opportunity and there's a discussion that should have been had. Patient education, people do not understand this, right? There's so much humor that plays into this, but we can't use humor to educate. We can use humor to build rapport, but we shouldn't use it to actually educate. And so that's sometimes as far as we get is education in building that rapport. Or I'm sorry, we use humor to build the rapport, but we never actually get to the truth of the matter and what the patient really is experiencing. And there's a lot of empathy that needs to go with that. And let me tell you, on this journey, the last 5 years, I've become presbyopic myself, and I have a very different perspective than I did, 5, 10, certainly 20 years ago. And the myth of it is it's complex. It's not complex. It's just that we have to be really intentional about it. We have to define our own success, and the patient needs to understand what's possible. And if we ask a lot of really good questions in an intentional way, we can get there together along with the patient. And if we utilize the people around us, our team, our director of first impressions, our opticians, our technicians, our scribes, this is an all like hands on deck kind of condition, right? And so we will be really well served if we understand where the patient is at that moment in time. And I have found that lifestyle impact assessments are key, and talking to our patients and giving our staff and our teams tools to actually use in the exam room so that we get consistent feedback. We have consistent question asking. These are all pieces that you can implement in your office. And I think that's where the real gap lies is we can educate ourselves. We can have great technology, but the implementation piece is hard, right? There's a lot of things that go into that. And so utilize tools to help us implement. And this is one way, certainly this is just mine, but there's a lot of these out there. You can make your own and customize it, and you're going to revamp it, and you're going to like some things, you're going to trash some things. But, having an understanding again of where the patient is utilizing their vision and where the gaps are so that we can fill those in a way that doesn't take longer than 30 seconds to a minute to prescribe, right? Because we're limited on time. I mean, 7 to 10 minutes is the average exam time. I typically see around 50 patients a day. So I don't have a lot of time, but the time I do have is very intentional and it's time well spent. And so I think this is a big piece of presbyopia is, again, understanding where the patient is. So utilize different tools. I love to understand how people communicate. And what also has helped me save time and be intentional is knowing how people communicate. And I don't mean words, words absolutely matter, and that is very important, but I mean the how. And I love utilizing different personality tests. We do that with our team, we do that to hire with, we do that to coach with. I do that on my own to, work on my self mastery and like try to be a better person and a better communicator because there's always a gap in communication. But I want to connect with my patients. And one of the ways that I have found to do that is, having a little fun with the refraction. And what I mean by that is not just going through the motions of, better one or two and like you're spinning and grinning all day. You can do that and like totally tune out, or you can tune back in and really listen to how the patient responds. And then you can utilize that information to communicate with that patient in the way that they want to be communicated with. And so I'll walk you through a fun scenario. When you're refracting somebody, we all have that patient that they get behind the phoropter, they start ripping off letters before you can even tell them what you want them to do. There's no directions. This is the person that opens, a box from IKEA and throws the directions away and just starts putting things together, right? That's a person and a personality style that doesn't need details, doesn't want details, is moving on to the next task. So you need not engage with a whole bunch of flu conversations. Just get to the point so they can move on with their day. That's a person with a D personality. Person with an I personality is someone that is chatting with you, telling stories. They haven't stopped talking since you walked into the room. As you're putting up the phoropter, they're still telling the story and they peek out behind to like make eye contact with you so that you can continue with the story, right? That's the kind of person that you're going to have to slow down a little bit and engage with them. They're the people that you want to invite to your dinner parties because they are going to be the life of the party and they're going to have great conversations. So you're going to spend some time there. If you have somebody that's an S, which is a steady person, they're going to they like to be safe. They're going to worry about how they answer. They're the person behind the phoropter that says, okay, wait, can you do it just one more time? Like one or two. Okay, two, I think, but maybe just go back to one to make sure. Oh, I hate this test. It always makes me nervous, right? Those are your patients that don't want to make a mistake. They need all of the information before they make a decision. So don't rush it. Let them make a decision, give them all the information. Don't be frustrated by the fact that they're asking questions. And then your last personality style, at least for the ones that we use, is a C personality, which is typically your pilots, your accountants, your attorneys sometimes, certainly your engineers. These are the ones that look behind and they, if you have a lineup that's like OC, TH, whatever, and they say, well, on one, H is better, but on two, C is better. Which one do you want me to look at and which one should I choose, right? We've all had those patients. That's a person that you are going to have to give every single detail to because they're not going to make a decision until you do. So you might as well settle in for the ride and give them all that information. But you can quickly see how just listening differently will give you a ton of tools to have better conversations with your patients. So look for those opportunities of what's happening in an exam room that maybe you've just gone into muscle memory and you've done it this way for, a long time and you want to shake things up a little bit. This is a fun one that you can engage with patients and really learn how to communicate well with your patients. Remind people and remind yourself that presbyopia is a journey. It looks very different at 38, 40, 42 than it does when you have absolute presbyopia at 55. And people need to understand, and our patients need to understand, this is a journey, and what works today might not work tomorrow. And what I'm offering you today, you may not need today, but you might want it tomorrow. And so teaching our patients what presbyopia is before they arrive there, super important. And giving them a runway of what that's going to look like, and that you've got opportunities to help them every step of the way. When people get nervous or they're fearful or they can't make a decision, it's because they don't have all the information. And they're fearful because in the absence of information, they're creating their own dialogues. So make sure that you educate that this is a journey and you're the trusted expert, right? You're the subject matter expert in all things presbyopia. Own that and watch what happens with your patients and who they refer. Understanding what their priorities are. It's going to be very different for someone that is an engineer that's working on a stand-up desk versus someone that's doing hot yoga upside down, right? There's different things and there's different situations for that moment in time. And you're going to prescribe based on the situation. You're not going to prescribe based on the person. You're going to prescribe based on the situation and how they want to use their vision at that moment in time. I think we really have to move away from this concept that there's a one size fits all. There is not. I mean, my patients wind up with multiple contact lenses, therapeutic drops, spectacles. I'll say it again because they have a primary pair, they have a workspace pair, and of course they have sunglasses. So we need to get past this approach that one size fits all, and our patients do not understand that, and we need to educate around this. It's going to serve all of us better if people understand and believe that. I mean, myself, I've got multiple spectacles depending on what I'm doing. I have 3 different contact lenses that I wear. And then I have therapeutic drops too. And someday I'm sure that I will have surgery. So I know what my runway is, and patients are always surprised and they are grateful when I talk about the multi solutions. Now, does that mean that every patient leaves my clinic with 3 spectacles, contact lenses, and therapeutics? Absolutely not. I wish, right? That's the unicorn that we all want. It doesn't exist in moments of time, but it might exist over a year or 2. And when they think and they're going through their day and they're frustrated, they're like, Dr. McGee talked to me about this and I didn't want it at the time, but you know what? Now I do. Now I see what she was talking about. I'm going back to get this. That's hugely powerful, is to just plant those seeds for tomorrow. And just reminding yourself and your patients too, patients really have to be frustrated enough to do something about it. And we are certainly frustrated enough to do something about it, but maybe we stubbed our toe on a certain technology and now we're a little gun shy. And I want us to move past that, whether it's a multifocal contact lens, whether it's a therapeutic, whether it's an IOL. Every patient is different, and we should be talking about all of these different options. We have a lot of solutions: spectacles, contact lenses, again, topical therapeutics, surgical options, and it's a journey. And at any moment in time, patients should have access to this. Go through this. Let them understand that you have presbyopia. This happens to all of us. It is a birthday thing, just like gray hair and wrinkles, but it hits people differently. It might happen for you when you're 40. You might be really lucky and it's not until you're 47, but I can help. And here's how I'm going to do that based on what you're telling me that you have a gap in today. It's that simple. Now, is it easy? Absolutely not, because it's taken me a long time to get to that simple message. And you guys are all doing the same thing in your clinics. It's just thinking about it a little bit differently. This is probably the most impactful conversation that has changed for me in the last 5 years. And it's neuroadaptation. And we talk about neuroadaptation with spectacles. You put somebody in a brand new progressive ad lens. How long do you make them wait before you change something? 14 days, right? Nope, you got to wear them for 2 weeks and then come back and then let's chat. Why do we do that? Because we need their brain to interpret the new image differently. Same thing with contact lenses. Guess what? It stands for therapeutic drops as well. And every clinical study that you look at over the last, however many clinical trials that have been done on presbyopia, every single one of them showed that at day 14, there was a bump in how patients read and did better at near. And then it stabilized, just like you would see with a contact lens, just like you would see with a spectacle. And so teaching people that neuroadaptation piece is super helpful, especially in a surgical candidate. Because if you tell the patient, listen, it typically takes you, and for surgical candidates, it's 6 months to 12 months to get the vision you're going to have for the rest of your life. And you'll see the patient like kind of sit back and go, what? I don't have 6 or 12 months. But the reality is we have completely changed your visual system. And the image that you now have on your retina has to form a new pathway to your brain to interpret. We have neuroplasticity. Thank goodness our brains allow us to do that, but everybody's a little bit different. And you know what the magic is in that? I've taken the technology away from that conversation. I've taken the doctor out of that conversation. I've taken the surgeon out of that conversation. And now guess what? It's up to the patient. And the conversations that you have with your patients when you talk about neuroadaptation are so much different when you can see the light bulb go off when they say, oh, okay, so my brain literally just has to adapt to this. Like it's possible for it to, yes, but it's not you, it's me. And so those conversations are very different than anything I had 5 years ago, and they're pretty special. So even if you walk away with nothing but that neuroadaptation piece tonight, I would encourage you to kind of build that out and like play with that a little bit and how you talk to patients, and just listen and watch their body language and how they interact with you differently, and how different your multifocal contact lens fits go, how different your post-op cataract, multifocal IOL conversations go, how different your therapeutic drop post, follow-ups go. It's different. So just walk through that with patients. Let them understand what neuroplasticity is and what neuroadaptation actually means. And, remind yourself and them too, it gets slower as we have more birthdays. So depending on when they're doing clear lens exchange or cataract surgery, that adaptation time can take longer. Critical age is 50 to 60. It becomes noticeably slower then. And guess what? That's when our patients are going to fall into with all of this technology. So understanding that and knowing that and being able to communicate that, super helpful. Just remind people too that we can only correct so many things. We can correct lower order aberrations, myopia, hyperopia, astigmatism. Higher order aberrations, more difficult, coma, trefoil, spherical. Those are all things that we can't correct with spectacles. We can correct some of it with contact lenses. But when you start changing people's visual systems and they have higher order aberrations, it can be challenging. And so getting people to understand this is huge. And this is part of that neuroadaptation piece. When you have higher order aberrations, our threshold for our retina to like notice that and for our brain to manage it is 7% in total. So if you go above and beyond that, and many times we do with surgery, all of a sudden our brain is like, ooh, we're on overload, I can't handle this. And we create blur and confusion until our brain can learn to interpret and see what's really happening here and form those new pathways. So that's what's happening behind the scenes. What's happening on the front end? Well, we have to make sure that arterial film integrity is optimized, and you guys know how passionate I am about the ocular surface. Corneal regularity, certainly keratoconus increases higher order aberrations. We've all had those patients, we fit lenses. Now we have things like CTAC that will actually change and lower those higher order aberrations so patients can see better without correction. So we have options there. Pupil dynamics and reduction in pupil size. That's where therapeutics come in, because we're creating depth of focus by making the pupil smaller. And, we're looking for different things with therapeutics and the ways that they work. We'll talk a little bit more about that. But then there's anatomical factors too, the lens cornea relationship, of course, axial length. As we start to learn more, and we're doing a lot more axial lengths because of myopia management, it's interesting for those docs that are doing axial lengths on everybody, on every patient. we've discovered that there's patients that we thought were low risk that are actually high risk because of their axial links. And so those anatomical factors play into this too. Um, so it seems simple on the front, but there's a lot here. So what I really want you to take away is you have to define success. And if you don't have that definition in your own mind, it's really difficult to be able to execute something that you don't even know when you've arrived at, right? So I want you to pause. And if you don't have what success looks like, I want you to define it. What does that really truly mean to you? Does that mean the 20 happy patient? Does that mean that, you've got a patient that you're putting in multifocal contact lenses and, it takes 2 lenses and then they're functional at 20/40 near and good distance? Does that mean you're using a therapeutic drop 2 to 5 days a week, or they're able to be less spectacle dependent at, dinner or in a society kind of event, or is it at work? Like, you have to define success for what your clinic is going to achieve, and then you can start to talk to patients about it. But these strategies and these systems are super important. You have to have an ocular surface optimization strategy. Make sure that you've got those protocols in place. Neuroadaptation education, we just talked about that, setting those realistic expectations and then defining success, knowing when you've gotten there. So we talked about this already. Spectacle adaptation, barriers, give them 14 days. Contact lens adaptation factors, multifocal, of course, takes longer than single vision. Center near designs require longer. And of course, anisometropia, and you start to have those larger disparities between right eye and left eye, then we can start to have longer factors too. We think and we believe that it begins actually at the retina level. Limit office changes to 2 or fewer. Otherwise, you're going to spend a lot of chair time and really not accomplish what you want to accomplish. Let patients wear it and let their brain start to meld with what's happening. Sight dominance, don't forget this. When you're doing contact lens fits, there's motor dominance, there's sensory dominance. Measure sensory dominance. It tends to be a lot more accurate. And, just put that 150 blur over each eye separately and which disturbs their vision the least, right? And record that so that's going to help you with your multifocal contact lens fits. Pupil size dynamics. There's been a lot of discussion here around, okay, well, what's the optimal pupil size? And it really, when you look at the studies, the smaller that the pupil size is, the increase in their depth of focus. And also something we should be considering is, okay, what's it doing to the ciliary body and how is that affected, as well as what's happening with the pupil? And what we know is as we have more birthdays, that our pupils do get smaller. And you see contact lens companies design their multifocal lenses to supercharge that. They do that intentionally and on purpose. They change the optics based on this fact. And so, with a therapeutic drop, that's exactly what you're doing, is you are basically taking nature and you're just enhancing it. Can you have reduced dilation capacity? I have not seen that with the therapeutic drops that we have. Less pupillary range. There was a study years ago that came out when Vuity first launched, looking at driving at night. And we did see that in that case, we were looking for, is it inferior? Is it the same? Is it superior? In this particular study, it actually was slightly inferior. So that's a warning. That's something that you're going to talk about with patients. Watch what's happening. Make sure that you understand that things could be dimmer. But also when you're decreasing pupil size, guess what? You're decreasing higher order aberrations too. So it's interesting. Some people, and just from my own personal, this is my clinical experience, not anything that's been studied, is some patients actually do better at night with pupil reduction. And of course, we've all seen that with our LASIK patients and, post-op patients, because they have less HOAs. So there's places that these drops will actually help people driving at night. It's not been studied in this scenario, but just know that. Our visual advantages when we decrease the pupil, of course, we're increasing depth of focus. We've all used a spectacle pinhole and the power of that. Remember that spectacle pinhole is 1.2 millimeters, the ones we use in the clinic. That will reduce 4 diopters of a prescription. If you change that pinhole and just add 0.8 to that, and now you're at a 2 millimeter pupil, you're only going to change 1 diopter. So it's not incremental changes. These are big changes based on pupil size. So that implication certainly matters no matter what we're talking about, but specifically with therapeutic drops. And then, if you're looking at ciliary sparing, of course, that is a conversation that we should have, as well as our pupil size dynamics. So it's pupil size dynamics as well as ciliary sparing dynamics. Those are 2 things that we should be talking about. Multifocal vision simulation. So this is what I experience now, and this is very hard to show patients, and it's very hard to understand if you haven't experienced it yourself. A monofocal lens is going to give you really sharp distance vision, distance and up close. If you have a multifocal, it's just, you can read it, but it's just got this weird blur to it. And it's hard to describe until you actually experience it. But I do think having, something in the clinic that kind of shows this, just so you can appreciate it yourself, is important. And then I think the biggest learning for us, and what I've learned, 5 years ago, 4 years ago, when our first therapeutic drop came out, is the difference between magnification and clarification. Because the gold standard that everyone compares things to is a pair of reading glasses that they just throw on, right? Well, what do those do? They magnify, they make things bigger. Our multifocal lenses do that too, but it's in a much more small way. And we've all had patients say, I just am frustrated with these progressives. I can't seem to find the right spot. They're doing the bobblehead game. Can I just have reading glasses? Well, you can, but now we have the contingency of they're sitting on the end of your nose. You got to take them off and on, right? There's pros and cons to everything. Multifocal contact lenses, we're extending that range. And then with presbyopia drops, there is no magnification. They cannot compare reading glasses to a therapeutic drop. The vision is completely different. It's depth of focus vision, it's clarification. So it's clearer because you have removed a lot of those outside rays, and it's a simple optics issue. And if you've played with the camera at all, you know this. Your broader depth of focus, smaller the shutter size, right? The smaller the pupil, the longer your depth of focus, more things are in focus along that whole plane. Versus when you blow that completely out, you're going to have 1 or 2 things in focus and everything else is going to be blurry. With presbyopia drops, it has nothing to do with magnification, everything to do with clarification. I don't think I can say that enough. And you really have to understand that and have to talk to patients about that. Otherwise, you're going to be frustrated because they're going to come back and go, well, I just see better with my reading glasses. Okay, is it better or is it different? That is a very smart question to set your patients up for so that they're not surprised by it. What I have found for me, the emmetropic presbyope is your low-hanging fruit. Those are the people, for one reason, they're never happy. They're frustrated. They want an option. They don't want to wear glasses. They don't want to wear contact lenses because they've never had to. And this also, I would put in this category, your LASIK people who invested heavily in their sight to not have to wear glasses and contact lenses. So for pharmaceutical presbyopia management, that's your low-hanging fruit. Those are the people that are most interested. That's where you start your conversations. And I promise some of you are on the other side of the screen going, yeah, okay, well, guess what? I don't see emmetropic presbyopes. They don't come into my clinic. And you are correct. A lot of them don't. But guess what? You just gave them a reason to. Because if you prescribe this, if we have a DTC campaign, if people talk about this, if your neighbor talks about it, if your friend talks about it, and they're like, yeah, I got this from Dr. McGee. And now you have an emmetropic presbyope coming into your practice that would never have come into your practice because they don't see the need for comprehensive eye care because they see fine. And you can see I'm putting all of that in quotes. There's so much opportunity there because those patients don't understand the value of what you provide. And those patients are also going to buy sunglasses, and they'll also buy probably workspace glasses, because now you're going to talk to them about the fact that, oh, I don't have to have reading glasses strung all over the house when I can never find them. You're telling me I can have a workspace pair that I can leave on and work on the computer and up close. What? You're going to give them a ton of value. And so those patients, that's where you start and you build some confidence. And then you move on to the lower hyperopes, the low myopes, making sure the patient has adequate pupil size, making sure their ocular surface is optimized. Those are where you start. Make sure you check all the boxes. When you think about, okay, let's look at all the clinical studies, no matter what medication we're looking for, the FDA set out that they all had to achieve the same thing. They had to do 3 lines of near vision gain without losing more than 5 letters of distance corrected visual acuity. So all of these companies and all of these therapeutic drops had to meet the same measure. That's equivalent to about a 150 to a 2+ ad, depending on the patient, depending on how much accommodation they have left. But here's the key piece. How do you know that a patient's going to be a good candidate? So when you finish your refraction that we just talked about, and now you understand how to communicate with the patient because you listen to their responses, and you have their distance correction vision in place because you've just refracted them, and you put the near card down. Before you do anything else, I want you to pause, and I want you to ask the patient what the lowest line they can read is with nothing in place, because that's going to give you their baseline, and it's not based on age. You'll be shocked at how many 46, 47-year-olds have J8, J100 vision, and you'll have some 55-year-olds that are J3. So that's something that I never did before pharmaceutical presbyopia management arrived, and we had a therapeutic drop for presbyopia. I never measured uncorrected near visual acuity, and now I do it on every single patient, because guess what? That lets me set expectations, because now I know if I have a patient that's 20/50, 20/65, and I can improve them 3 lines over a period of time, that's highly functional, right? Now, if I have somebody that's 2200 up close, are they still a candidate? Maybe. It depends on what they want to achieve. But at least it gives us a metric and a bar in time to be able to set proper expectations. That is like the biggest clinical pearl I can tell you, is doing that near point test save you a ton of time. So we all know this. I'm not going to belabor this, but I will belabor clarification versus magnification. You got to talk about that. So, advanced visual correction strategies for presbyopia. Start to marry things together. You guys are all super confident with contact lenses and spectacles. Get really confident with workspace glasses, with starting to mix and match things with therapeutic drops. Where does this fit? Can I prescribe this for this situation with the patient? And then once we arrive to, okay, now let's talk about some surgical approaches, or let's marry some other things together, right? We got to make sure that the retina is super healthy, and this should be applied across the board. But, we started doing this years ago when we were doing multifocal implants. And it was just starting to become a thing 25 years ago. And lo and behold, we would put in a multifocal IOL and find out the patient has an epiretinal membrane, and gosh, we should never have put that in the first place, right? So just do your due diligence and make sure that patients are good candidates for the technology that you're putting them into. You've got to look at the retina. I don't care if it's wide field or dilated, just look at the retina, make sure there's no thin places, no issues with vitreomacular traction, no issues with epiretinal membranes. That way, when you send to the surgeon, that way, when you do a therapeutic drop, you've already got everything. You know this patient and their anatomy, so that like where we are. Don't forget that step, and you guys aren't going to. So let's talk about surgical patient selection, just as we've kind of rolled through this, right? So we've got, early presbyopia, moderate presbyopia. Now we're at absolute presbyopia, or maybe a little bit sooner. But giving patients this timeline is important. And people that are in their early 40s, I still talk about this. By the way, this is an option. I wouldn't do it now because you've still got, the ability to focus. But certainly, I want you to know that this is available to you, so that when we get to that bridge, you know that there's a path forward. And you can literally see their body language, their shoulders come down from their ears, and like, oh, okay, I have an option, right? People just want to know that they're not locked into something and that this is not going to be forever and that they're not going to continue to lose near vision. That's another big one. They think they're going to continue this for the rest of their life. It's going to max out around 55 to 57, depending on the patient. But for surgical patients, you've got to know their history. We have to understand, and you all know their relationship. You have that. You spend time with your patients. You know the ones that are engineers that should never be in a multifocal contact lens or a multifocal IOL because they cannot handle the dysphotopsias and they can't handle glare and halos at night. So you're going to put in that chart, surgeon, do not put in a multifocal IOL. That's a patient for an LAL, maybe an extended depth of focus, maybe it's just monofocal, but certainly not a multifocal. Anatomical factors, of course, pupil size, where their angle kappa is, looking at that optimal lens selection, adaptation timeline, talking with them that it's 6 to 12 months. Set that before. My surgeon and I have a saying that if it happens before surgery, it's an explanation. If it happens after surgery, it's an excuse. Nobody likes excuses. Those conversations don't go well. But explanations, great. So whatever your preoperative assessment and protocol needs to be, then make sure that you've got that in place. You guys have done this for years, so you already going to have protocols in place of what you want to have before you send them to the surgeon. But you need to be in the driver's seat. Again, your surgeons are leaning on you to give them all of the information so that they can best serve that patient, right? They don't know their personalities. They don't know their history. It's super important to be able to collaborate in that way. And it's really a cool relationship between the three of you, the surgeon, and the patient. When it works well, it's a beautiful thing to witness. So potential adverse visual phenomena. Of course, patients can have photopic phenomena. They can have dystopic. It can be things that they see, glare and halos. It can be the absence of, those patients that will have dark spots in their vision right after cataract surgery. That's a negative dysphotopsia, right? It's patient reassurance. Their brain's going to get used to it. But there are these things that can happen, whether it's insufficient, vision quality, they're going to have reduced contrast sensitivity. And then they can have some biological things that happen if they get a PCO, if they have residual refractive error, if their brain just cannot handle it. And sometimes that happens, right? So, if you're going to think about an IOL explantation, here are the questions that you have to ask in a presbyopia correcting lens. You have to ask, did you ever see well? Was there a moment after cataract surgery that you saw well? If the answer to that is yes, that is the PCO is certainly part of that conversation. And you can talk about doing a YAG capsulotomy. If from the moment the patient got off the table and their vision was never clear, do not touch that PCO. Make sure, because at that moment in time, you might really need to consider an explantation, 3 or 6, 9 months down the road. And we don't want an open bag that's going to make your surgeon's job a nightmare. And so just understanding that and knowing that timing is everything there. There's lots of options here. We're getting more approved like every year, every 6 months. We've got our monofocals, we've got our enhanced range, we've got our extended depth of focus, multifocal, trifocal to help patients with their distance, intermediate, and near. Do I understand all of these lenses intimately? I do not, but I understand my patient and I understand what their needs are, and that's what goes in the chart. And I will put recommendations to my surgeon. Hey, consider LAL because of X, Y, and Z. This is what we talked about. Patient desires least spectacle dependence possible. That gives them a runway. I'm not locking them into something, but I've started the conversation because this is a hard conversation. This is technology they're going to have for the rest of their life. And so I want them to have every piece of information possible. You guys drive this conversation. Do not be afraid to have those conversations with your surgeons. Do not be afraid to put that in the chart. They are begging you for that kind of information. Dysphotopsias, we've talked about. There's positive photopsias, negative photopsias. So, Positive is characterized by unwanted light perception. So that's your halo, your glare, your starburst. Your negative photopsias are characterized by the absence of light perception. So that's when they get that dark crescent-shaped shadow over here in their peripheral vision. It's often their temporal visual field. It's more common with high index acrylic IOLs, but it gets better. But tell your patients, I understand it's totally normal. If you can do your best to ignore it, your brain will eventually ignore it for you. Don't blow them off, but lean into that. It usually disappears in days, weeks, rarely months. But these are just visual simulations. And maybe you have some of these things like, strung around in your clinic that you can educate about. And fortunately or unfortunately, patients have the right to have more than one of these. So, just understanding what they are seeing, super helpful. There's a ton of IOL technologies out here. I'm not going to go through this. We do not have time. We could do a whole 2-hour lecture just on IOL technologies. But what we should know and what we should be talking about is, again, here's the indications. We have presbyopia. Are we going to do an RLE? Do they have cataracts? Is this going to wind up being an RLE/cataract? What are the negative patient factors? Do they have pathology like a epiretinal membrane? Are their expectations too high? Are they too young? Are they still, have some accommodation left? Are they 20/15 distance, right? That's a patient I really don't want to recommend for surgery. That makes our surgeon's job super hard. Very large pupil size, type A personality. Those are all things that go into that. And then, your preoperative is going to be however you set your protocols. And then we just talked about the post and the adverse events that can happen. Clinical success factors in premium IOL surgery with presbyopia. You got to match the technology of the patient. You got to align their needs with their expectations. And expectations are the key piece in that conversation. You're shooting for refractive precision. So, maximum residual error tolerance for optimal outcomes is half a diopter. 95% satisfaction rate when we get that married right, but start talking about 6 to 12 months adaptation. Managing expectations is the foundation for success with any presbyopia management. Therapeutic drops, IOLs, contact lenses, spectacles. Spend some time here on managing expectations, your own and your patients. Here is what our patients want. This was a study that came out a few years ago looking at setting proper expectations. Here's what our patients expect. Look at this. Seeing clearly in all situations. Freedom from glasses. Freedom from the worries of forgetting glasses. No need to switch or add pairs of glasses for different activities. Reduce dependency on glasses or contact lenses. Increase freedom to participate in sports. No need to change glasses every couple of years. Those are expectations. We can't meet those. Those are clearly unrealistic. But patient perception is everything. And so it's up to us to have the conversations of, I can absolutely make you see clear in all situations. Here's what that looks like for you. I can help you be less spectacle dependent. And here's what that looks like for you. Here's the pros, here's the cons. I can help you in this situation. I can help you in this situation. The one on here that makes me laugh the most is the no need to switch or add pairs of glasses. How many pairs of shoes do you own? One? You're gonna have a hard time walking in flip-flops, to your running on the beach or going to the gym. We have high visual demands that demand high visual, trying to think of the right word I want to use, high visual solutions for that. And it's not just one, but our patients don't know that, and they don't know what they don't know. And it's not fair for them to continue on in this perception that they only get the right to choose one thing, right? We have ways to help people in multiple things now. The communication, satisfaction, connection. I love this image of this 6 and 9. I think I've communicated well. The patient walks out and says something totally different. You got to listen for that. You have to practice that, and you'll get a huge investment or you'll get a huge return on that investment when you intentionally put those parameters in place to have better communication and understand what your patient is really motivated by. And we've all had those patients who are like, gosh, This patient's super motivated. They do not want to wear contact lenses. And they're like, I'm going to do this. And you put them in a translating GP for the first time at 47 years old. And you know what? They crush it. And you could do that with another patient that's a great candidate, worn GPs their whole life, and they're miserable. So that X factor that you can't really put a finger on and you can't really measure, but you can hear, that is a big factor in any of these. You have to understand what the patient's needs are. You have to understand what their emotional need is. Where are they at this moment in time? Are they ready to hear this information? What are they willing to commit to? And do they have the capabilities of adapting to it? So that patient motivation, that X factor, that is a big piece of, therapeutic drops, contact lenses, any of these. Patient has to be motivated. Don't try out a brand new therapeutic drop on the patient that has failed in every other presbyopia technology that you've put them in, right? It's not the patient to start to build your confidence with. Put it in somebody that's really highly motivated. Structure that expectation accordingly. I love this image. This is not how we want to define success. Cross our fingers, close our eyes, and hope for the best. It's not it. Choose patients wisely. I would challenge you tomorrow, listen on those refractions, utilize that near point card to understand where the patient is right now in that moment in time, what they're able to read without any help at all, with their distance correction in place, understand their personality, start to implement, if you don't already, a lifestyle questionnaire so that you can really get into those questions. What do they want to accomplish with and without spectacles? Talk to them about the neuroadaptation periods. It can be as simple as this question: would you like to have a drop to make you less dependent on your glasses? How long did that take me? Right? That's as simple as it has to be. This was an hour-long lecture that looked and sounded probably fairly complicated, but it is that simple. Do you want to have a drop that makes you less dependent on your glasses? Start there. And then see what the patient says back to you. Make sure you manage the ocular surface. I can't give a lecture without talking about that. For the sake of time, I don't want to go into a lot of cases because you guys see these patients all day, every day. You treat presbyopia, you manage presbyopia, you prescribe for presbyopia, but maybe you haven't been as intentional about presbyopia as you could be. Maybe it's been a minute since you've thought about how I talk to patients with presbyopia. Maybe it's been a moment and now you guys are all educated on presbyopia. And then if you go through with intention, education to you and the patient and your team, you have implementation strategies of how you're going to see these presbyopia patients. And it do not reinvent the wheel. Do not make this hard. Don't overcomplicate it. Charge for what your time is. Make sure the patient is a great candidate. All you have to know in that point is what you do every day. You look at their retina. You make sure they don't have thin places, holes, tears. You make sure the patient's a good candidate and charge for your services. It's cash pay, doesn't have to go through insurance. That's very straightforward. And then set expectations. If you do those things, you will have an entire pillar of presbyopia in your practice that will feed every single pillar of what you already have. If you have an optical, it will build that. If you already do contact lenses, it will build your contact lens clinic and certainly your specialty contact lenses. And I consider multifocal contact lenses specialty contact lenses. And your surgeons will start to send you patients because they know that you're going to optimize the ocular surface. They know that you are going to educate the patient in a specific way. They know that you have got their back and you guys are in this together. You're going to build every single pillar that you already have, and you're going to create a new pillar of presbyopia that is going to feed you for the next, however many years, because guess what? We spend half of our lives presbyopic, and we need options, and we need different options and different solutions to meet patients where they are. So hopefully that gives you some nuggets to take away and think about tomorrow as you're going through clinic and you're listening to your conversation about presbyopia. and you're curious of, how can I say this differently? Did I see that that landed in a certain way? Let's play with this verbiage. Let's change this. Let's tweak that. So if you have questions, there's my email address, Dr. McGee at srmconsulting.org. And then this is up next, one of my very best friends, Mark Blumenstein, talking about when you might want to treat. One is too many. Thank you guys for joining in. I really appreciate your time tonight.
Thank you so much, Dr. McGee. That was amazing. I learned a ton. And I love those pointers at the end. That was amazing. I'm going to use some of those tomorrow, I think. Um, so basically, there's a question about by therapeutic drops, is there anything besides Vuity that you use?
So we have another one. So Vuity was the first one, right? 1.25% pilocarpine. We have Closey now, which is 0.4% pilocarpine. So different, same MOA, but less strength as far as some of the side effects and looking at that. So those are both still available. There's two that are currently under FDA investigation. So Lens 100 has a product that their PDUFA date for aceclidine is in August. And then 10 Point has a drop that is carbachol and bromonidine that they just applied for their FDA approval, I think 2 to 4 weeks ago. It's been very, very recent. So we have two currently commercially available, two on the horizon.
Wonderful. Well, that's what we have time for tonight. Thank you so much, Dr. McGee. Really appreciate you being here. Super honored to have you on behalf of the WooU team. And with that, I'd like to thank everyone for joining us and also Lens Therapeutics for the education, for exhibiting at this event. And we hope to have you again soon, Dr. McGee. Thanks again.
Awesome. Thanks, Dr. Kramer. Great to see you. Great to see
You
everybody.
too.
Stay on. I think she's going to put the QR code on for you guys. So,
Yes.
okay, awesome. See ya.